Hi, I'm Mike Haynes. First, I'd like to welcome everyone and recognize each of you for attending today. That's because you're taking a very important step towards improving your health and your life. I'd also like to thank all of the doctors, nurses, and advocates and families like mine who are working so hard to fight and win the battle against prostate cancer. I stand before you today as a prostate cancer survivor. Prostate, cancer, survivor. Sometimes those words stick in my mouth, no matter how many times I say them, because I never expected to be a prostate cancer patient. But thanks to the love and care of many people, I'm here today to share my story with the hope of helping others. I've had lots of memorable moments in my life, like playing in the Super Bowl and being inducted in the Pro Football Hall of Fame. But the one day, the one moment I will never forget was when my doctor said, "Mike, you have prostate cancer." That knocked the wind out of me, more than any hit I ever took on the field. I was stunned. It all began during the 2008 Hall of Fame weekend. The NFL Player Care Foundation had partnered with the American Urological Association Foundation to provide retired players free prostate cancer testing. I didn't think I needed it. I'd recently had a physical exam and thought I was in the clear. Plus, I was pretty healthy, a green tea and yoga type of guy. But after some convincing, I took the screening test at a similar event to the one you're at today. And that simple test saved my life. My doctor gave me the news in his office with my wife, Gigi, by my side. I have to say that having her there made all the difference in the world, because once I heard the C word, cancer, my mind went blank. I didn't even hear the doctor tell me that I had cancer in 9 of the 12 areas of my prostate surveyed. Thank goodness Gigi took great notes and asked a lot of questions. Thankfully, we caught the cancer early while it was treatable. Together, my family and I, we learned about all the treatment options and decided to go with minimally invasive robotic surgery to have the prostate and my cancer removed. I wanted it out of my body. I'm not saying surgery was the easiest thing I've ever done, but I was able to get through with very few side effects. And I'm just grateful, so grateful. But I know not all men are as lucky. I was pretty shocked to learn that 1 in 6 men in the United States will be diagnosed with prostate cancer in their lifetime. And for African American men, the news is much worse. They're twice as likely to die from the disease. Those numbers have got to change. Too many men are needlessly dying of prostate cancer because they just don't know the facts. So, how do we change this? We start talking to each other about our health and keep talking. I know that's a crazy idea, men talking to men, but trust me, it can really make a difference and save lives. When I was at a low point about this disease, it really helped me. Also, we have to listen to the women in our lives when they tell us to go to the doctor. I've also learned a lot about taking charge of my health. When facing cancer, I've learned how important it is to talk to your doctor about all the treatment options to determine the best choice for you, to learn all you can about the treatment you choose, and to find out about the side effects, and to find out about the recovery. As for the step you're taking today, I want to wish each of you the very best. And remember, you don't have to let prostate cancer take you out of the game. Know your stats. I did, and that means I have many more memorable moments ahead. For more information, visit knowyourstats.org.
Good evening. My name is Tom Barron. I'm a urologist, a human plumber, and we're going to talk about prostate cancer tonight and the minimally invasive prostate cancer removal with the Vinci robot. Now, what is the prostate? The prostate's a male sexual gland. It adds nutrients and fluids for sperm and also provides income for urologists. The fluid is added to the sperm during ejaculation. Urethra, a urine channel, runs right through the middle of the prostate. Now, prostate cancer consists of abnormal cells that grow out of control. They spread, they invade local tissue, and prostate cancer begins with a small tumor in the prostate gland. Many times it's multifocal, originating in different areas of the prostate. And then initially, if it escapes the confines of the prostate cancer will spread to local lymph nodes. Then it spreads to bony skeleton areas, liver, and lungs. Now, in the picture, you can see a normal prostate right here, and then there's an abnormal prostate, which is kind of lumpy and bumpy. And on rectal examination, it feels like there are little lumps inside the prostate. Now, prostate cancer is the most common non-skin cancer in America. And as you saw from the initial video, it affects 1 in 6 men. It's the second most frequently diagnosed cancer in men and the 6th leading cause of cancer death in men. Now, currently, 91% of prostate cancer that's diagnosed in the United States is clinically localized. This is totally different than 30 years ago. In the United States, the 5-year survival rate for prostate cancer is 99% versus less than 80% for many other developed nations. Now, when you stage prostate cancer, you stage it with several different modalities. One is the prostate-specific antigen. The other is digital rectal exam, transrectal ultrasound, and the pathologists give us a score called the Gleason grade, which tells us how aggressive the cells appear. Bone scan is often used to stage prostate cancer. In some men, we'll do a CAT scan or an MRI, or more rarely, a PET scan. And the biopsy in the staging system is TNM, which stands for tumor, nodes, and metastasis. Now, in T1 prostate cancer, the prostate tumor really can't be felt on a rectal examination. If a gentleman had a transurethral resection of his prostate because of an enlarged prostate, it occupies less than 5% of the specimen. It's T1B if the cancer is found in greater than 5% of the resected tissue. T1C is a cancer that's found only because the PSA was elevated and the prostate felt normal and someone had a rectal examination, which was also normal on rectal exam. Now, in T2 disease, the tumor can be felt during a digital rectal exam. T2A is classified as felt on 1/2 of one side of the prostate. T2B is felt on 1/2 of both sides of the prostate. And T2C is felt on both sides of the prostate. Now, T3 disease means that cancer has spread beyond the prostate. T3A is extracapsular extension, where it penetrates the prostate capsule in these areas here or here. And T3B is where tumor invades the seminal vesicles here. T4 disease means that cancer has invaded local organs and tissue, such as the bladder muscle or the pelvic side wall, or the patient may have pain in joints in the back because of tumor metastasizing to bony structures. Now, one question is, what do the biopsy results mean? And the prostate cancer is graded on the appearance of the cancer cells. The Gleason grading system ranges from 1, which is the least aggressive pattern at the top, to 5, which is the most aggressive pattern. And the Gleason score is between 2 and 10. The most common cell grade that the pathologist sees in the specimen is added to the second most common grade. So Gleason 7 at the bottom you can see is a 3 plus 4. You could also have a Gleason 7 which is a 4 plus 3, which means the predominant cells are grade 4, which is more aggressive than the grade 3. Now, when you diagnose somebody with prostate cancer, one of the first questions that the vast majority of patients ask is, what are you going to do about my prostate cancer? And we always give the patient a number of options. And our philosophy is that we want the patient to be as well educated as possible about their disease, because it's their prostate, their life. They're the one that has to make a decision as to what they want to do. Now, surgery is one option, and that's a radical prostatectomy where we remove the entire prostate gland. That can be by making an incision, or by using laparoscopy, or by using the Vinci robot system. Another option is radiation to the prostate, either through an external source, getting 42 treatments on average, or one-time radioactive seed implants into the prostate, which is called brachytherapy. Another option is called freezing the cancerous prostate, and this is called cryotherapy. Yet another option is hormonal therapy, which is non-curative and often done in conjunction with either radiation therapy or cryotherapy. And there's another option, which is observation, called watchful waiting. Now, in removing the entire prostate, the most important thing is to remove the entire prostate gland. One of the advantages for the Da Vinci robotic system is effective cancer removal. You have great magnification. You can do a much more elegant operation than you ever could before. The patient has a quicker recovery and quicker return to normal urinary function. There's also a better chance of preserving the neurovascular bundle that's responsible for sexual function. And you can see on our diagram, this is the bladder area, this is the pelvic floor, and the neurovascular bundle is a plexus of little nerves and vessels that runs underneath the prostate. Now, why do a Da Vinci robot for prostatectomy? It provides superior visualization where everything is magnified greatly and you're utilizing robot arms to manipulate the tissue, incise the tissue, cauterize the tissue, and remove the prostate. And you can see the 3D high definition view that you get with the Da Vinci robot compared to laparoscopy where you only have a two-dimensional view. And this gives you a perception of depth. And this is a unique system. And you can see here the prostate and the tissue being gradually pushed away. It also enables meticulous dissection of all of these structures. And the instruments have a full range of rotation for the operator's wrist. As far as the time frame of how long does it take to remove the entire prostate, it should take usually about 2.5 to 3.5 hours. This compares favorably with open surgery, which is about between 2 and 3 hours. Now, one of the other advantages, when you're removing the entire prostate, you have to reanastomose or reattach the bladder to the urethra. And With the Da Vinci robot system, you can do a much better anastomosis with a running suture than we ever could before. So this means you can make the anastomosis as urine tight as possible, then you have less scarring. And you can see the robot arms manipulating the needle here, reattaching the bladder to the urethra with the prostate missing. Yes. Now, when you compare the Da Vinci surgical system using a robot compared to an open incision like we have done for many, many years, the open incision, this is the belly button, this is the symphysis pubis, so you have a long longitudinal incision. With the Da Vinci robot, you have a series of small little incisions and oftentimes one other little tiny incision here. So you have a series of smaller incisions, not only to do the surgery, but also you usually get the prostate out through this middle incision here. You make it just a little bit wider. Now, because the entire prostate gland is removed with radical prostatectomy, the major potential benefit of this procedure is a cancer cure in patients in whom the prostate cancer is truly localized. If the cancer is not localized to the prostate, removing the prostate is not going to completely cure the patient. Now, up to 35% of tumors can actually be more aggressive than the pre-surgery assessment and biopsy results indicate. And this is because when we're biopsying the prostate, we're getting a portion of the prostate cancer. Several millimeters away, there may be more aggressive tumor cells. When you choose surgery, it enables easier detection of the cancer recurrence through PSA monitoring after a radical prostatectomy than after radiation therapy. Because when the prostate gone, the patient's prostate should be as close to zero as you possibly can get. With radiation, the PSA does come back up a little bit because the prostate's still there. Now, if you surgically remove the prostate and the patient has a recurrence, then you can radiate the area that used to be occupied by the prostate if you can ascertain that prostate cancer cells are there, so it gives you an additional treatment option. Now, as far as long-term survival and localized prostate cancer control is concerned, there was a study of 3,159 patients and found that 15 years after treatment, those who had undergone radical prostatectomy had a 40% lower risk of death from prostate cancer than radiation patients. If you look at this graph, this is a study over 10 years that shows the survival rate for surgery at the top in yellow compared to other treatment modalities such as watchful waiting, radiation, other therapy, and hormone therapy. Now, as far as long-term survivability, why should we be focused on just a 10-year survival rate for older patients? Today, an average 65-year-old man in the United States can live for another 18.4 years, so the 10-year survival rate is extremely important. Now, there's a lot of clinical concerns for a prostatectomy. Three of the most important things that you want to be concerned about: did you adequately control the cancer? Are all the margins positive? Is the cancer truly confined to the prostate, or did it penetrate the capsule of the prostate? The other concern is urinary incontinence. Are you going to leak urine after surgery? Another concern is potency. Are you still going to be able to function sexually after surgery? Now, as far as cancer control with the Da Vinci surgery, there were 4 different studies, and the positive margins range from the left 2.5% to 4.8% on the right. With any of the other treatment modalities such as surgery or brachytherapy, you really have no idea whether there are any positive margins or not because the prostate's still inside the patient. There's a faster return to continency with the Da Vinci robot compared to open surgery or laparoscopic surgery. And a lot of this is because you can do a much more meticulous dissection with the robot, and you can do a much better anastomosis between the bladder and urethra with the robot. Now, as far as symptomatology goes, as far as pain, patients with the surgery seem to have significantly less pain than people that have radiation, both at 2 months and at 24 months. As far as sexual function with a Da Vinci robot, there is a much higher level of sexual function after 1 year with the robot compared to other types of open surgery or with radiation or brachytherapy. Now, one thing that there's always a warning that you have to warn patients about. If you want to have the most potent patients after surgery, you want to operate on everybody under the age of 50, because then you're skewing your data, basically. If you have people that are 70 or 80 years old, many of these patients have potency problems before surgery. The surgery is not going to correct that. Now, the Da Vinci robot is a minimally invasive surgery that has numerous potential benefits compared to traditional open surgery. You have a shorter hospital stay, significantly less pain, less blood loss, fewer blood transfusions, less scarring, and a faster return to normal activities. Now, this is one ad by the Da Vinci robot company that patients like their prostate cancer removed rather than leaving it in place. Now, if you look at Da Vinci surgery compared to open surgery, with Da Vinci surgery, you have fewer positive margins. The hospital length of stay is about 1.2 days compared to open surgery, which can be average 3 days. Major and minor complications are less with robotic surgery. Urinary function returns to normal, and sexual function has a better chance to return to normal with the Da Vinci surgery. One of the other things that's so important with the robotic surgery is the expertise of the surgeon doing the surgery, because this is something totally different than we've done in the past, even different than laparoscopy, because you're operating at a remote console that you can see back there, and so there's a significant learning curve. So you want somebody who's done hundreds of these, because then they have the best chance to have the shortest operating room time, shortest hospitalization, and the lowest amount of complications. The other thing that's very important is the person that's assisting the surgeon, because you have to have somebody who's standing by the robots exchanging different robot arms. There are little scissors, different types of graspers that we use, and so you have to have somebody who's very facile at this, assisting the surgeon. Any questions? Yes, sir. No, the question is, since you have such a great view and magnification with the Da Vinci robot, this really helps us see cancerous cells. It really doesn't allow us to see anything on a microscopic level. You see it on more of a macro level, and you can see the prostate and everything better. Because with the Da Vinci robot, you're looking towards the prostate from the head, where all the instrumentation goes in, your view is in. With traditional open surgery, you're looking directly down on the prostate, most of which is hidden by the symphysis pubis. So you have a much poorer view at open surgery. But it doesn't allow us to microscopically see anything, but we can do a better dissection of getting all the tissue out than we ever could before.
That's really the basic.
Yes.
You have a better view, so you're able.
Loma Linda?
Loma Linda
Right.
University in California. Specifically in this county.
Yeah, one question was about the proton beam form of radiation therapy for prostate cancer compared to traditional IMRT radiation. And there is a proton beam device up at Central DuPage Hospital in the Chicago suburbs up there. In addition to Loma Linda, it's my understanding that the first one was at Loma Linda. And I've seen patients who have had this done, and they seem to do as well as patients with traditional radiation therapy. They had some issues, they had some complications. There's no therapy that is 100% complication-free, whether it's surgery, any type of radiation modality. And I'm not sure as far as the data goes, since it's not been in widespread use, how advantageous that would be compared to conventional radiation therapy. I did ask one of our radiation therapists about a year ago if he felt that that was a significant advantage, and it was his opinion that it wasn't.
Other thing I did learn, downside is the insurance very likely.
Right. You know, the thing you have to be careful of with any type of medical device or anything that anyone has, if you buy it, then you want to use it a lot. And you always have to try to put the patient's best interest. When something's in use for a long period of time, then you have an opportunity to decide, is this really better than something else? Prostate cancer is sort of a dilemma for us in following patients, because prostate cancer tends to be very slow growing initially. But on the other hand, a lot of times you don't see a recurrence of the prostate cancer for a number of years. And I've had the pleasure of being in Springfield since 1981, so I've been able to follow many patients for a long time. And I've seen patients do well for 8, 10, 15 years, whether they've had surgery or radiation therapy. But I've seen some of those same patients fail after year 10 or year 12. So I think only when you get a large number of patients treated and followed for a long time do you really get a sense of whether something is better or not. But I think one of the things that they talk about, like you mentioned with the proton beam therapy, it's very precise and maybe doesn't damage other tissue like some of the other modalities do. But on the other hand, the prostate is still there. So if the prostate's still there, one of the concerns you have with any type of radiation therapy is, are you going to get a second primary develop in that prostate 5 years, 10 years, 15 years from now? If you have somebody who's 80 years old, 15 years from now may not really be a major issue for that patient. But you get somebody who's 45 or 50 years old, you know, they probably are still going to be around 15 years from now. So those patients may have more of a vested interest in wanting to do something that might give them a more optimal chance to be cured.
Online is
Right. Your statement was that it's the safest course. Well, when you remove the prostate, it's outside the body. It's sitting in the pathologist's lab. The only time it's going to spread is if there were positive margins or some cancer cells that microscopically escaped from the confines of the prostate before where you really couldn't detect these by any other means. Yes, sir.
If you talk about the PSA and validity of that test, the issue of scores that might indicate biopsy is indicated, and the velocity of rays drive, as well as the biopsy process.
Those are a lot of good questions. I have some slides on that, and let me get to that slide area. That may address many of those questions very nicely. Yep, let me get my correct folder here. There is a study out recently by the U.S. Preventive Services Task Force and prostate cancer testing, and some of the results that they came up with were rather confusing. And this task force was an independent panel of non-federal experts in prevention and evidence-based medicine. It was composed of primary care physicians such as internists, pediatricians, family physicians, gynecologists and obstetricians, nurses, and health behavior specialists. This entire panel did not include any urologist or oncologist. So you have obstetricians, gynecologists, and pediatricians who don't see male patients with prostate cancer coming to conclusions about what you should do with prostate cancer or the PSA blood test. Now, the Affordable Care Act broadened the scope of this panel, mandating that the group must assess, develop, and update clinical preventive recommendations. It requires that Medicare and qualified commercial plans cover those preventive services graded A and B by this task force at 100%. Grades of C or D require copays. Now, in May 2012, following the release of this task force, the Obama administration told the Associated Press that Medicare would continue to pay for the PSA test. Now, the U.S. Preventive Service Task Force makes recommendations at the population level that must be implemented at the personal level to you. The goal of prostate cancer testing is not only to prevent mortality, but even more so to prevent the attendant morbidity that comes with metastatic prostate cancer, such as urinary tract obstruction, fractures, and significant bone pain. The most effective way to prevent advanced metastatic prostate cancer is to detect it early, before it spreads. Some prostate cancers are aggressive, advancing quickly, and threaten the life of the patient. Some are very indolent, slow-growing, may never become life-threatening in that man's lifetime. The only way to know if either one of these exists is to be tested. The PSA test is the most widely available test to identify changes in the prostate. It's prostate-specific, but not cancer-specific. The PSA blood test is not going to help you detect any other cancer except for prostate cancer. Currently, there is no other widely available blood test for prostate cancer. Many patients ask me that they've read something in the National Enquirer, the Wall Street Journal, the New York Times about some test that's coming out. Well, I've heard this for 10 years. I'm still waiting for another test. Nothing has come out yet. When used appropriately, the PSA test provides clinicians with valuable information to aid in the diagnosis and treatment of prostate cancer. Before the PSA era, when people were residents like I was in the 1970s, prostate cancers were most commonly found following the onset of symptoms from advanced disease or as a nodule or lump felt on digital rectal exam. Half of those patients that we took to surgery that had a prostate nodule had disease in their lymph nodes already, or in their bone, or both. Symptomatic tumors were a higher grade, more advanced, and often more deadly. Now, during the PSA era, we've had a 75% reduction in proportion of people who present to us for the first time with metastatic prostate cancer. There's been a 42% reduction in age-adjusted prostate cancer mortality over the most recent 20 years. Most of the models that they've run have suggested that 40 to 70% of this reduction is due to early detection of prostate cancer. Most of the studies analyzed by this task force demonstrate benefits from PSA testing. The task force underestimated the benefits of testing, and they overestimated the harms, which relate more to treatment of prostate cancer rather than the specific PSA test. There was a prostate, lung, colorectal, and ovarian screening trial. More than 76,500 men were enrolled, ages 55 to 74. The prostate cancer detection rate was much higher, 12% higher in the screening arm. But this was imperfect due to pre-screening contamination of the control arm. In a European randomized study for screening of prostate cancer, it demonstrated a 21% risk reduction in prostate cancer-related death, up to 29% accounting for noncompliance, and benefits were observed primarily in men younger than 70 years of age. The number of cancers that would need to be detected to prevent one death has dropped to 37. There's another study out of Gothenburg, and it was a population-based trial of 20,000 men. It demonstrated a 41% decrease in advanced disease and a 44% relative risk reduction in prostate cancer mortality in men aged 50 to 64 after a median of 14 years. PSA testing, though, is not a black and white issue. The best practice guidelines put out by the American Urologic Association show that early detection and risk assessment of prostate cancer should be offered to asymptomatic men 40 years of age or older who wish to be screened, and with these men having an estimated life expectancy of more than 10 years. Men who wish to be screened for prostate cancer should have both a PSA test and a digital rectal exam. The decision to use PSA for the early detection of prostate cancer should be individualized. Patients should be informed of known risk and potential benefits. The American Urologic Association strongly supports that men be informed of the risks and benefits of prostate cancer screening before biopsy, and the option of active surveillance in lieu of immediate treatment for certain men newly diagnosed with prostate cancer. Who is at highest risk for prostate cancer and may derive the greater benefit from screening? Men of African ancestry, 40% more likely to be diagnosed, and a 245% greater prostate cancer mortality rate. Anyone with a family history of prostate cancer on their father's side. Anybody who's had a PSA greater than 1 at age 40. A rise in PSA does not automatically mean that a man needs a biopsy, or does not automatically result in a cancer diagnosis. Prostate cancer diagnosis doesn't automatically mean that a man needs treatment. There are other things besides prostate cancer that can elevate a PSA. Recent instrumentation with a catheter, a patient having a urinary tract infection, prostatitis. These all can falsely elevate the PSA blood test. The current community standard is that active surveillance should be offered to appropriate patients, low-risk disease, limited life expectancy, patients who do not wish to pursue aggressive interventions. The bottom line is that a patient cannot make an informed decision about prostate cancer if he doesn't even know he has it. So, takeaway points: not all prostate cancers are life-threatening, not all require active treatment immediately. However, you can't do anything if you don't know a cancer exists. The decision to test for prostate cancer should be individualized to the patient. Men should understand the pros and cons of testing. And prostate cancer testing is necessary in order to provide patients the most options, including active surveillance as early as possible in the progression of their disease. Now, the gentleman asked several other questions. One was with regard to the rise in PSA over time. If you have 3 consecutive PSAs and it rises by more than 0.75 each time, even if the PSA, the last one, is still within a normal range, that rise makes us suspicious that the patient might have prostate cancer. And I don't remember if there were any other questions that I didn't address with the slides. If you could please refresh my memory.
Comments about the biopsy procedure process and what if any are the risks or the positive and negative of that?
Well, those are excellent questions about the biopsy procedure and the risks that one can have from having a prostate needle biopsy. Well, when you do a prostate biopsy, we usually do 99% of these in our office. Then we insert a small ultrasound probe in the rectum that's just a little bit bigger than my finger. And we measure the volume of the prostate, and we look for any abnormal areas in the prostate or seminal vesicles. Then I inject a local anesthetic into the neurovascular bundle. This is the nerve supply of the prostate. Then I wait about 15 to 20 minutes and come back in the room, and usually at that point in time, in 99% of the men, the prostate in this whole area is nice and numb. So I re-examine the prostate with ultrasound, looking for any abnormal areas. If I see an abnormal area, I can biopsy that specifically with a spring-loaded gun. If the entire prostate looks normal, then I sample tissue from each area of the prostate to get a good representative sampling. And this involves taking about 6 to 8 cores of tissue from each side. The more tissue I give the pathologist, the more they're able to help us. Now, this is done as an outpatient. The patient is placed on antibiotics 3 days before the biopsy, gets an additional antibiotic intramuscularly the day of the biopsy, and goes home with 3 more days of antibiotics. We do this to try to prevent any type of infection. However, despite our best efforts, each one of us will have 1 patient per year who gets fever and chills afterwards, has to be hospitalized, has to have IV antibiotics. Another risk is some patients may have some rectal bleeding. This usually clears up very rapidly. Some patients may have some blood in the urine. This usually clears up rapidly. Some patients may have blood in the semen, and this usually clears up rapidly. So those are the basic nuts and bolts of the procedure and the various risks that are associated with it. And one of the other risks is that a patient may have prostate cancer, but their prostate feels completely normal on rectal examination, and the prostate looks completely normal on ultrasound, yet their PSA is 8. Well, we're basically trying to find a needle in the haystack, basically. And we're hoping that we're in the right place at the right time. But that doesn't always happen, so some patients are going to be biopsied 2 or 3 times before we can make a diagnosis of prostate cancer. We don't want to find prostate cancer in everybody, but we certainly don't want to miss the diagnosis. But sometimes it can be exasperating for us and the patient. Yes, sir.
Say you've done all this, you still find nothing. Are you going to write it off or what?
No, it depends.
Out of the night, he knows he's dying, but he don't know where.
Well, you know, the question is, what if we do biopsies and we don't find anything and the PSA is still elevated?
You make a recommendation from that.
Well, there are certain things. Number one, all our testing, all our normal values pretty much are based on a bell-shaped curve. Sometimes you have outliers. And there are some men that produce more PSA than normal, yet they do not have prostate cancer. But I don't have any tests that I can identify those men, and I worry about missing prostate cancer, so those men, like everybody else, get biopsied. But there have been several men that I followed for 10 years. Their PSA is 6, then it goes up to 8, drops down to 5, goes up to 6, drops down to 4, goes back to 8. Their PSA keeps on bouncing around, but there's no persistent upward trend. Those men, to the best of my ability, don't have prostate cancer, but they seem to produce more PSA than normal. If I do multiple biopsies on someone, say 3 separate sets of biopsies, yet their PSA keeps on going up, and on rectal examination everything feels normal, in some of those men I'll do a transurethral resection of the prostate where we go into the urethra and bladder with a scope and use an electric loop to carve out all the tissue that I can from the prostate to present the pathologist with a large volume of tissue that they can make an awful lot of slides out to look and see if there is any prostate cancer. Sometimes I've found prostate cancer that way. Sometimes all that tissue is normal and the PSA drops down to a normal range. Any other questions? Transrectally, we can't biopsy lymph nodes or bones, but I can biopsy the seminal vesicles to check if there's any prostate cancer in the seminal vesicles. And sometimes we'll have a patient who presents with a hard lump in their prostate. The prostate is fixed to the pelvic sidewall. You really can't move it. In those patients, I always make sure that I biopsy the seminal vesicles because if there is invasion, this really upstages the patient's prostate cancer. As far as biopsying any lymph nodes, you'd have to have a very enlarged lymph node to be able to see it, to successfully biopsy that. We'd have our radiology colleagues do that. Biopsying bone, sometimes we'll have our orthopedic doctors biopsy a bone. One patient that I recently had prostate cancer, and he had it on both sides of his prostate, so I did a CAT scan, which was normal, and a bone scan. And the only place that the bone scan had a lesion was in his left arm, his left humerus. No place else. And usually, by the time it gets to your arm, it's going to spread throughout your backbone and pelvis. But I had one of my friends, the orthopedic guys, biopsy it, and it did come back positive for prostate cancer. So that changed the way we're going to treat that patient. So sometimes we will do a bone biopsy. Yes, sir? As far as the bone biopsy goes, the amount of pain that they usually have is either done under an anesthetic or they use a lot of local anesthesia. Same thing for any lymph node biopsies. There's 2 questions. One is, what role does diet have in prostate cancer? And the other one is the CyberKnife that they have up in Bloomington. As far as diet goes, the recommendations are to not eat a lot of red meat, not to eat a lot of, well-cooked food like, when you fry bacon so it's really crisp and has a lot of nitrites in it. The recommendations are to sort of stay away from things like that. The one thing that bothers me is, 1 month you're going to hear something on the news or read in a magazine that something is bad for you. The next month you hear that it's good for you. But the problem is you look at all of us in the room that are here, with the exception of this young guy over here and the ladies in the background, for us, how much difference are we going to make right now if we have a big dietary change? You've been eating red meat all your life, so have I. So, we're changing something abruptly. I'm not sure if it really would make any big difference. It might make a difference for your grandchildren. Now, the other issue, the CyberKnife, is more of a precision type of radiation therapy. They have one in Bloomington, Illinois, that you probably saw advertised on TV. And this allows you to use computers to try to pinpoint the radiation a little bit more accurately. But I'm not sure if that gives you any better control compared to the other radiation modalities. One thing I forgot to mention about the Da Vinci robot system and removing the prostate surgically is that when you remove the prostate, you do remove the lymph nodes. And occasionally you'll find somebody that has microscopic cells from prostate cancer in their lymph nodes. You only know that if you operate on the patient, remove the lymph nodes. You don't know that if you do radiation therapy, the cyber knife. You don't know it if you do proton beam therapy because you don't know the true extent of the disease. Fortunately, because of the PSA blood test, most of our patients present really early in their clinical course, so most of the patients that we remove the prostate on do not have positive lymph nodes. This is compared to the area before the PSA blood test when half of the patients had positive lymph nodes. Yes, sir. Well, you know, the recommendations are if you're African American, once a year starting at age 40. If you have a family history of prostate cancer, starting at age 40. If you don't have any of those two items, then starting at age 50. And there's also a question that goes with this: when or should you stop PSA testing in someone? And this is a very hard question to answer. Certainly if you have somebody who has bad heart disease and they're 80 years old, they have bad diabetes, bad vascular disease, whether or not that individual has prostate cancer is probably a moot point because they're not going to die of the prostate cancer. On the other hand, you know, people are living longer because of those darn cardiologists. They have all these great medicines, they have these cardiac stents, all of these great procedures that they do, so they've really extended many people's life expectancy tremendously. And so, you know, maybe the new, you know, 80 is the new 70 now, basically, because people are living longer, they're healthier. So instead of cutting off PSA testing at an early age, you might want to extend it for a while. And it's also up to the patient. You know, nobody forces the patient to have a blood test. The patient needs to decide whether he wants to have something done. And it's the same thing with the therapy for prostate cancer. You want your patient as informed as possible because then the onus is on that patient to make a decision as to what he wants done. It's not my prostate, it's his prostate. Yes, sir. I think it's very difficult for stress. As far as occupation goes, some individuals have been exposed to a lot of toxic compounds, and they've never been told about it. And this is not so much so in private industry, but in the military. Many of our soldiers were exposed to Agent Orange, as have civilians. And finally, the Army and the military now is coming out with, you know, recommendations as to how people should be tested, that it might be involved in many, many different diseases. And this is only one thing that we know about, Agent Orange. Think about how other people might have been exposed to different things. So I think there can be occupational hazards such as the military, and you know, you can have somebody in good faith working at a company that has some type of chemical or something, and you may not know for 20 or 25 years that this might increase somebody's risk of a certain disease. You only know sometimes after the fact. Any other questions? Well, thank you all for coming tonight. I hope this was informative. And Joni will help you with the robot if you want to play with the robot a little bit to see what it feels like and test your skill. Yes, sir.
I just like to say that I have it was just a delight to be able to see up close. I guess I was even closer to the equipment
Yes.
at one point, but I have no recollection.
Well, thank you. Any other questions at all? Very good. Thank you very much.
Thank you.